dose? Antipsychotics, how much is too much? How low can it go? What we're going to focus on today really is the second of the SD consult objectives, and it's going to be looking at the rationale for treatments appropriate for psychotic illnesses with the particular focus on dosing. So it was difficult to figure out exactly where to start. So we're going to start with guidelines. So the PORT guidelines actually very clearly spell out some of the recommendations regarding what treatment doses should be targeted. So their treatment of acute patients, they are recommending that first-generation antipsychotics use between 300 and 1,000 chlorpromazine equivalents. And then they give some ranges for the second-generation agents. For maintenance, they really recommend a somewhat lower dose, so 300 to 600 chlorpromazine equivalents. And this is where they include the dosing recommendations for some of the long-acting injections. For some of our first episode patients, they do recommend avoiding the use of olanzapine or clozapine, and also making sure that the dosing is really reserved for that lower end of those dosing regimens that are up there. So really kind of the bottom half. So recognizing that there are some relatively clear evidence-based recommendations for this, I just wanted to highlight that we may have a problem with the dosing in general. I used the first episode data just because there are very specific recommendations to use lower doses in this population. So this was a trial by Dr. Robinson and colleagues that looked at prescription data from their recovery after initial schizophrenia episode project, so their RAISE project. So this was 404 patients, and they reviewed all of the prescriptions that they had. So you'll see on the left-hand side, there's the list of all the agents that they had with the median dosing and the mean dosing, as well as the dosage ranges. As you can start to see, some of those dosage ranges really are not in the bottom half of the dosing interval. So it was identified that more than 40% of the first episode patients that were involved in this project had indications for changes to their pharmacotherapy regimen. So in approximately 10% of them, the doses were too high. In about a third of them, they were given olanzapine when it really was recommended to stay away from olanzapine or clozapine first line because of some of the side effect profiles. In about a quarter of them were on multiple antipsychotics. So it really was looked at that we do have some room that we could potentially improve, not just with our first episode patients, but with everybody overall. One of the reasons for this is there's some emerging information on both sides of this argument. So there is relatively robust evidence to support that the use of antipsychotics decrease the risk of relapse in patients with schizophrenia. So if they're able to stay on the medication long-term, the risk of relapse is lower. It's also, in looking at some of the imaging data, that relapses seem to be associated with reduced brain volume in patients with schizophrenia. So individuals with more chronic severe disease tend to have greater reductions. But the flip side of that is there are some imaging trials that are coming out now. So there's both animal and human data that suggest that there may be a relationship between reduced gray matter volume and the use of antipsychotics. So in animal models, specifically in 2 monkey models, they found that there's been a reduction, especially in the frontal gray matter. And then there was a longitudinal trial that was done, I believe it was in Iowa, where they have been serially providing these patients with schizophrenia with MRIs to follow their disease course and to map it out. And what they actually have found is that there was a greater decrease in gray matter and it correlated with an increase in the antipsychotic treatment. So the greater the intensity of antipsychotic treatment, more medications, higher doses, the greater change that they saw. And that was different from the actual disease itself. So that was kind of controlled for the amount of symptoms that the patient had. So there's a growing dialogue that talks about, so are these drugs neuroprotective where they help, or might they be neurotoxic in some instances? So the bottom line for all of them is we really need to use the lowest effective dose that we possibly can. So one of the first questions that comes out is, do those low doses work? The answer is yes. We are going to do a quick look at just a couple different dose finding studies. Both of these are first in acute patients. So this was a look at differing doses of risperidone in acutely ill patients that had schizophrenia. So they were given a 1-week washout, they were all inpatient, and then they were randomized in a double-blind manner to risperidone 2, 6, 10, 16, haloperidol 20, or placebo. So the doses were titrated over the first week, and they were evaluated at a number of times. We're going to look just at that baseline to endpoint evaluations. What they found was that all of the patients that were on medications improved in their clinical global impression of severity. So in all instances of active medication, they all seemed to get better. For the clinical global impression improvement scale, all but the low dose risperidone showed improvement compared to placebo. So it looked like all those patients were moving in the right direction. One of the suggestions was potentially 2 milligrams was too low for the severity. So these patients were not early in their disease. They tended to have, most of them had between 0 and 5 hospitalizations and had quite a few years of illness under their belt. So potentially that was a little bit too low. When they looked at the actual symptoms, so they used the PAN scores, they found that reductions in the higher doses of risperidone and haloperidol were superior to placebo. And in positive symptoms, all of the risperidone doses were different from placebo. So what this means is we may be able to effectively treat some of these patients with some of the lower doses of risperidone. 6 milligrams, or even in some cases 2 milligrams, because it did have an impact on their positive symptoms. In looking at the tolerability, there was an increase in dyskinesias with some of the higher doses of the risperidone. There was not a difference compared to placebo for the haloperidol group for dyskinesias. They did have more Parkinsonian symptoms though. So tolerability does look to be a concern with those higher doses. So if we can maintain the efficacy and minimize those adverse effects, that's really the window that we would like to be looking at. I will acknowledge that this is a little bit of an older trial. They really weren't looking at the remission criteria, so more just response. How much did those symptoms change on the PAN scale? A quick look, and I chose these two because they really had the broadest range of doses to take a look at. So this is just a trial looking at quetiapine doses. Again, it was done in inpatients, so they had a 1-week washout period, and then they were randomized to one of the quetiapine doses, so 75, 150, 300, 600, or 750. Haloperidol at a slightly lower dose of 12 milligrams a day, or placebo. They were titrated over a week to 2 weeks. Some patients in the higher doses of quetiapine actually took a little longer than a week to get up to dose, and then they were maintained on that dose. They were looking at changes in the brief psychiatric rating scale, so just part of the PAN scale. On the right-hand side, we have a graph that has 3 different bars. So the blue bar is the baseline values. So between all of the groups, they were about the same. Patients were in the mid-40s, so they were kind of moderately ill and symptomatic. By the end of 6 weeks, for the quetiapine 150, 300, 600, 750, and the haloperidol group, there was a significant decrease in the BPRS score compared to placebo. So they saw a greater change in the symptoms for those patients. The symptom improvement overall was between a 15 to 20% reduction. So these patients weren't completely well or in remission. Their symptoms weren't totally gone, but they were definitely moving in the right direction. What I also did want to point out, because I think it is a concern to look at efficacy alone, is the tolerability. So there was no difference in dropouts in this trial, but they all had about half of the patients drop out or withdraw from treatment. So as you see, the low dose actually had quite a few that dropped out 68%, and then our higher dose had 52, haloperidol had 65, and the placebo had 69%. So really trying to find that balance between having tolerable adverse effects but giving an adequate amount of efficacy is going to be really important, and it's going to be tricky with the number of these agents. So overall, it does look like we might be able to use lower doses. There was not superiority seen between the higher doses of quetiapine and the lower doses, similar to the fact that there was not superiority seen between the higher doses of risperidone and the lower doses. So it looks like we could potentially use some lower doses in the acutely ill. Many of you may work outpatient, so maybe more looking at the maintenance therapy. So could these low doses work for maintenance to be consistent with what's recommended in the treatment guidelines? So one of the treatment options that's been introduced for maintenance therapy is long-acting injections. So this was a look at trying to use low-dose haloperidol decanoate against placebo in patients who had been chronically ill. So these patients had been given 15 weeks of haloperidol at 60 milligrams every 4 weeks. So that was equivalent to about 3.5 milligrams orally of haloperidol. So these patients were then randomized to either continue receiving haloperidol decanoate or to receive placebo, and then they were followed for 48 weeks. In that time, they actually measured the haloperidol serum concentration every 4 weeks when the patient came in to get their injection. So they serially measured those plasma concentrations. What they found was that there were significantly more relapses with placebo. So almost 70% of the patients who were transitioned to the placebo group had relapsed by the 48 weeks. They started to see a difference right around 8 weeks, and that correlated with the time that the haloperidol serum concentrations began to decrease. In the haloperidol group, they only had 11% relapse over that same period of time. And as they looked at broadly at all of the data that they had, they showed that the serum concentration of haloperidol actually correlated relatively directly with the risk of relapsing. So having the drug on board definitely was beneficial to prevent the relapse, but these patients, even though they had been chronically ill, were able to be maintained relatively successfully at a lower dose of haloperidol decanoate than what we may traditionally see in practice. So long-acting wise, that may be beneficial. Another potential advantage of looking at lower doses is there is a suggestion that maybe lower doses may be masking negative symptoms or changes in cognition, that the antipsychotics may actually make those worse in higher doses. So this was a trial that was a multi-center open-label 28-week trial. They looked at patients who were on at least 2 milligrams or more of risperidone and at least 5 milligrams or more of olanzapine. So there were 61 patients. Their positive symptoms had to be in remission, so no evidence of positive symptoms and no dose changes in the last 3 months. The average risperidone dose was about 4. The average olanzapine dose was about 14 at baseline. So what they did is they took those patients and reduced their dose by a quarter, by 25%. They then followed them out for a month. As long as they were still doing well with no symptoms, they reduced their dose by another 25%. So they were at about 50%, and then they followed them for the duration, the remaining 24 weeks of the trial. They measured their cognitive function. So they used the repeated battery for assessment of neuropsychological status, the RBANS. I had to look this up. I wasn't as familiar with this one. So it is a proprietary product that uses a number of different subtests. So they look at verbal comprehension, immediate memory, long-term memory. I forget what the other 2 categories are, but they have a number of subscales. It takes about 30 minutes for it to be administered. It was originally designed to look at individuals who had dementia. So individuals who have Alzheimer's disease on average score about 70. So you'll see at baseline, our patients were about in the 70s, 78, 83. Huntington's disease patients were actually at about 83 as well. So they were relatively impaired on the cognitive functioning scale. At 28 weeks, what they saw was there was a significant change in those individuals who had reduced their dose versus those who just stayed completely the same. So some of that may have been due to a withdrawal, so that they were seeing a lot less adverse effects, and then they were starting to potentially have too much anticholinergic on board. So all of their side effect rating scales, especially the movement disorder scales, all dropped pretty significantly. But it didn't sound like they were at the same time getting rid of all the anticholinergic medications that may have been on board to treat those adverse effects. They also, for the group that had their dose reduced, saw an improvement, a mild improvement in their BPRS score. So even though they had cut that dose in half, they were able to see that their symptoms were maintained over that period of time. So there is potential that we would be able to maintain some of these patients who have been doing well and are stable on a lower dose and reduce their side effect burden, and then maybe get rid of some of those auxiliary medications that are also on board. They've also found data, there was another trial that looked at later life schizophrenia, where they also reduced doses of risperidone and olanzapine. This time it was by about 40%. And they saw similar findings, that they didn't see an exacerbation of symptoms and their adverse effects improved significantly. So looking a little bit more broadly, there is a meta-analysis that included 13 studies in over 1,300 patients. So this included trials that looked at standard dose versus low dose or very low dose antipsychotics. Their primary outcome was for treatment failure, and it was treatment failure for any reason. So it could have been efficacy, it could also be tolerability or exacerbation requiring hospitalization. Their definitions, what they used as standard doses are those in the middle column there, the defined daily dose. And just as a reminder, I kind of teased you with this last week, the defined daily dose is defined by the World Health Organization, their collaborating Center for Drug Statistics. So it's one of the average daily doses that they can use to treat patients with schizophrenia. For our low dose group, they were looking at about half up to the full dose that's defined there. So for quetiapine, it would be any dose from 200 milligrams up to 399 milligrams. For risperidone or ziprasidone, it would be from 40 milligrams up to 79 milligrams. For the very low dose group, they used individuals that were on less than half of that. So the very low dose group included individuals who were on quetiapine at less than 200 milligrams or ziprasidone at less than 80 milligrams. And I just included the port recommended doses just for reference on the side. So what did they find? So what they looked at low dose versus standard dose for treatment failures. And I'm gonna start from the very left-hand side and then we'll work our way to the right-hand side. They did not find a difference in those first 3 lines. They looked at second generation agents, low dose versus standard dose, and first generation low dose versus standard dose. Then they pooled them all together. There was no difference in the risk of treatment failure of low dose versus standard dose for these patients. Most of these trials included patients who were not necessarily first episode patients who may have been sick for a longer period of time. So for that group, they did not see a difference between. So it does suggest that using lower dose antipsychotic medications would be just as effective as using standard dosing of antipsychotic medications. For the very low dose, they did not find a difference for the second generation or for the first generation, but as you notice, that confidence interval is much larger, especially for the second generation agents. So when they pooled that data together, what they found was that the standard dosing was actually less likely to have a treatment failure than the very low dose was. And that's the last line on the right-hand side that has the little star. So if that relative risk ratio had been below the 0, it would have been in favor of the very low dose. Because it's above, it's actually in favor of the standard. So going low may be very beneficial, but we may not want to be too aggressive and go incredibly low, especially if the patients begin to have some symptoms. So in summary, there's a lot of information and a lot of trials looking at multiple aspects of what's the most appropriate dose for our patients. There's genetic testing information that's out there that's trying to predict who would respond best and who would be successful in coming off or reducing their dose of medications, but we're not there yet. So the best recommendation really is to continue to revisit this. So having continuous antipsychotic medication definitely has been shown to reduce the risk of relapses, which may then potentially preserve some brain functioning and brain matter. But some of the doses may come at an adverse effect, and some of the antipsychotics may carry their own neurotoxicity. So it's going to be very important that we're making sure that we check that balance to maintaining symptom control and making sure that we're at the dose that the patient needs, that they're not experiencing problematic adverse effects, and that we do potentially challenge and reduce the dose slightly to see if the patient could be successful on a lower dose. I think that's all I know. That was slightly over my 15 minutes. That was tough to get in a short period of time and do it justice.